So somehow I might be guilty of making some extreme statements here that is just to jolt your attention to this topic. So I feel that THE has been ousted wrongfully from the management algorithm of CAG junction. It features in all the algorithms, but it doesn't feature in practice. The next evolution is two major changes in management which has happened. This can actually impact the role of this choice of procedures in C. esophagus. One is neoadjuvant therapy. We have to see this entire data because most of this data is from pre-neoadjuvant era. With the advent of neoadjuvant therapy, we might have a case where THE might fare better than what it did already. And the advent of minimally invasive techniques that can actually mitigate a lot of criticism about it being a blind procedure. So what does neoadjuvant therapy do to the lymph nodes? Obviously, after neoadjuvant therapy, the lymph node yield decreases. Many lymph nodes disappear, lymph nodes get sterilized, their size gets smaller, and the pathologist might miss them during assessment. So that's why they say more than the absolute number of lymph node ratio might be a better use when you assess stage a patient after neoadjuvant therapy. And post-neoadjuvant CTRT, the lymph node yield fails to be a consistent predictor of prognosis. There is a clear recommendation as to how many lymph nodes you must resect in a upfront surgery patient, but that does not happen after neoadjuvant CRT. But this should not mean that you will do a suboptimal resection or a very limited lymph node resection in post-neoadjuvant patients. The surgical quality has to be maintained, but we have to wait and see how this is going to play out in future studies. So the recommended lymph node harvest is 16 for upfront surgery according to NCCN, but after neoadjuvant therapy, they don't make a very clear statement. They say it's probably you should stick to the same number. So as neoadjuvant chemo-RT has become the standard of care for locally advanced C. esophagus, the argument that THE is inferior due to its lower lymph node yield may not be significant in the future. Minimally invasive surgery has gained rapid access into esophageal surgeries, and even though the thoracoscopic approach is most favored, minimal invasive surgery has also made THE a much more under-vision operation and has helped to decrease morbidity and lymph node yields. So we have laparoscopic esophagectomy, which has been there for more than 2 decades now, a lot of papers on that. There is also a mediastinoscopy assisted THE, and the latest kid on the block is the robotic-assisted MIE, which has really made access into the mediastinum much more easy. With the 3D vision, you are able to achieve a similar type of lymphadenectomy and on-block resection as you would do with a thoracoscopic approach. There are studies on this, lap versus open THE. This study compared lap as open THE, and they found that laparoscopic THE was better in lesser blood loss, lesser ICU stay, and lesser hospital stay. And the radicality of surgery did not change between lap and open THE. There are also enough studies on robotic and laparoscopic THE in Siewert type 2, and these have clearly proven that minimally invasive is better than open in terms of both surgical safety, and the oncological radicality was similar. It was not better, but it was similar. So we can go on to say transhiatal resection may be as reliable as a transthoracic esophagectomy in the treatment of CAG junction in terms of surgical morbidity and oncological adequacy. When you look at the NCCN guidelines, when you see the surgical strategy, NCCN just lists out all the surgeries possible. It does not actually prefer one procedure over the other for G junction. You can see transhiatal esophagectomy being in that list. That's what I said. It's there in the guidelines, but it's not in the practice. So after this, how many of you will start doing THE instead of TTE in your practice now? Will you consider doing it? Before you take that decision, you also have to understand that in C. esophagus cancer treatment, apart from the procedure, surgeon experience, hospital volume plays a very crucial role in outcomes. So just because the evidence shows one procedure is equivalent to the other doesn't mean you have to convert. Surgeon expertise and hospital volume has been proven to be a very important factor in achieving good morbidity and acceptable oncological outcomes. So we can, if you are trained in TTE, continue to do TTE in a good way. If you are in a center where THE is being practiced and you know how to do a good THE, and if you can use the help of robot and laparoscopic do it, do a good quality THE. There is no, the purpose of this is not to prove one is better than the other. It is to say that THE has a definite, robust oncological role in managing CAG junction. So a definite role exists in early cancers which are not amenable for endoscopic therapy in the GE junction, which is not like Barrett's, and in Sievert's type 2. And in future, as more evidence evolves in the era of immunotherapy and neoadjuvant chemo-RT, where the role of lymphadenectomy might go down, and you may not be required. We have already seen the evolution that lymphadenectomy has, the role of lymphadenectomy has been diminishing, where more radical lymphadenectomy no longer recommended. There might be a time when all GE junction cancers can be managed with a THE. This conclusion has to be read with a lot of caveats. THE done by an expert surgeon in a high volume center, preferably with minimally invasive techniques, can be as good as a transthoracic esophagectomy for GE junction carcinoma in the near future. Thank you.